Thank you, Umesh and Rajshekar, and my dear friends. I think from yesterday afternoon till now, we've been talking about access, repeated interventions to keep a AV fistula patent, but no one has really addressed the issue that PD is an alternative, and I think that's going to be the basis of my talk on long-term peritoneal dialysis being an option. And we don't have that much technology. We just take a catheter out and put it back if there is a problem with the catheter or infection. So emergent start PD is the basic idea is to, I'll try to be as fast as possible. It's a 100-meter run. Emergent start PD, it's a new concept that's developing worldwide. And PD was considered less an option. I think PD is getting a stepmotherly treatment all over the world. And everyone knows it's been stressed again and again, but people don't seem to be taking any note of that a central venous catheter is a time bomb waiting to explode, and as much as you can avoid it, it is better. So what we are doing in our unit is urgent start PD. I'll talk to you exactly what urgent start PD is and what we are doing. Unfair to PD option practices is there in spite of the default therapy as of now is putting in a hemodialysis catheter in a sick patient and starting hemodialysis straight away without even discussing and telling the patient and the family the option is that we need to put a central line and start the patient on dialysis in the intensive care, even in the hemodynamically unstable septic patient. You're talking CRRT, you're talking of SLED, but you're talking basically of a central venous catheter, and we have seen the problems. All the entire meeting was probably discussing about complications of central venous catheter sequelae. We are talking of the parachute landers or the crash landers who are patients without any treatment for their renal failure. They land into the ICU. And if we start PD within 14 days of putting in the catheter, it's called urgent start. But I am specifically concentrating on what is called emergent start. So emergent start is a subcategory of urgent start where we start PD within 48 hours of catheter insertion, which really is a very, very viable alternative to starting hemodialysis. And this is a very important point in red there. The generally held perception that PD catheter insertion should be performed at least 6 weeks before starting PD is based on evidence level C. So make note of that. And I think urgent start PD in our unit at least is a default option. That is, we counsel the patient and tell them because of very positive, strong positive aspects of PD, and then it also increases PD uptake on the long run. When you have a fistula in hand, the patient will say, I have a fistula, I want to start dialysis, hemodialysis rather. You have a PD catheter in place. When the patient comes out of the coma, he'll say, I have a PD catheter in place, I want to start peritoneal dialysis. And this is a paper we presented and we highlighted what we did in our unit. And but here you have to be very careful and you have to start the counseling very soon. You have to do a fast forward counseling of the patient socioeconomic status and the medical aspects of the patient, and a good surgical support where the surgeon is crucial and has a backup surgeon when he's not available to put in the catheter under local anesthesia. Basically, there are some measures which I'll come to know. Even a laparoscopic insertion or Vitek insertion is possible, but basically a local anesthesia or spinal anesthesia is used. Sometimes a bimodal approach is necessary where there are extenuating circumstances where only a hemodialysis can be done initially for things like severe metabolic acidosis or hyperkalemia. And the nursing support, they have to be trained very well. To initiate urgent start, the nephrologist must, and the team must decide on dwell volume. So you have varying amounts of dwell volume depending on the body surface area, and the number of exchanges can be decided on how much urea generation or catabolic status of the patient is. Emergent start PD for special situations, for AKI definitely, because recovery is faster and the patient becomes lucid very fast and they can participate in their treatment. Avoidance of dialysis disequilibrium. We have problems of hyponatremia and hyponatremia and uremic encephalopathy coming together, it's very risky to do hemodialysis. You can produce what is called the central pontine myelolysis, where we really had a patient like this, and we do co-current flow, reduce the blood flow. Still, the correction is 10 milliequivalents in less than 3 hours. So it's probably very risky to do that. And urgent start PD. We had a patient who probably would have been saved with urgent start PD rather than doing hemodialysis. He had central pontine myelolysis and died. BiModal approach is for hyperkalemia, severe metabolic acidosis, night admission, and we do 1 to 2, maximum 2 sessions, and then shift them, put in a catheter and start them on peritoneal dialysis. You can see the neckline for this patient, but he was started on emergent start. You can start a patient on urgent start and then do a smooth transition to CAPD at home. You can see this patient who was started on a cycler. And here you can see the patient emergent APD followed by in-hospital CAPD training and then back home. We are using the Mitra cycler purely because it is less expensive and is very user-friendly. And we perform 7 days of this is called the M cycler, and we use 7 days of immaterial of whether they're going to go on long-term APD or are going to go on manual PD, and they all started on PD in the ICU or in the rooms even. And we had all our patients were started on emergent PD, and we had, if you can see here, our dwell time was 30 to 35 minutes. PD full generally was 8 to 10 hours of treatment, and 10 liters was what was used. And 8th day we started the training for manual PD if they wanted manual PD. 33 patients were started from April 2016 to 2017. 4 mortalities due to serious coexisting comorbidities, with 29 patients doing well with this approach, which is fairly good. 6 out of this patient with ESRD opted for APD at home, and 12 opted for CAPD at home on manual PD. 11 patients recovered from the AKI, which probably is a difficult number to achieve with hemodialysis. Of the 12 CAPD patients, 4 had exit site leak, 2 restarted on PD, 2 remaining 2 shifted to hemodialysis. 1 had peritonitis, which successfully treated. 3 had catheter blocks, and with a non-surgical approach with repeated enemas, it cleared off. 2 patients went on for cadaveric renal transplants. You need to do what is called ambulate them. Don't ambulate them when there's fluid inside, because that can lead to a leak. But when they are not, there's no fluid in, you should make them ambulant so that the catheter goes down into the pelvis, through pelvis. And anchoring by the technique the Japanese have described called PVAT, where the catheter is stitched onto the posterior wall of the anterabdominal wall, posterior surface. So these are the studies, but none of them have done emergent start PD. These are all urgent start PD, and these are their frequencies. Our study, all emergent, 750 to 1000 ml, 8 to 10 hours daily. And there's been a recent paper from David Johnson's unit in Australia, in Brisbane, and it's still not available in print, but it's on online. And they have validated our findings, but they also did only urgent start, not emergent start. So conclusion is that it's a new hope for patients who wish to opt for PD only and are unfit to undergo hemodialysis. Waiting period, hemodialysis during the waiting period in hemodynamically unstable patients with central line is definitely a no-no. Our excellent results should prompt more centers to emulate our and the nephrologist is the champion to spearhead an emergent start PD program. I hope many of you are listening and try to implement this. This will increase PD penetrance in your units.
Questions or remarks?
Yeah, and the last slide is, I would like to welcome you to Hyderabad for the International Society of Blood Purification Congress that's happening August to September in Hyderabad. This is an amazing meeting where all the latest cutting-edge technology in dialysis, peritoneal dialysis, apheresis, and other sepsis management will be discussed. Thank you very much.
Okay. Yes, so any questions on emergent PD? Dr. Nayak, you are using cyclers in any patient, or all of them were banned?
All cyclers.
All cyclers. There are none. Yes, sir.
Previously, when we were doing PD by the stiff catheter, this emergent PD was something which was a routine. But since the use of the soft catheter, which was mainly started for continuous ambulatory PD, the concept of emergent PD is something which is not catching up. It has actually totally disappeared, and except for some people who think about it, practically I think if you take a vote, there are very few takers for this. But I personally feel that this is one way to go if you want to prevent the complications of central venous stenosis. It may be that the workload which the nephrologists and interventionists are going to get may come down if we have the PD combined with in the waiting period till the fistula repairs. I'm not even saying that do this for keeping these patients for maintenance PD. You should do it even for patients who are going to be on maintenance hemodialysis till the fistula matures.
I agree, yeah.